So we're going to talk for the next 10 minutes about perfusion assessment for critical limb ischemia. We look at a lot of angiograms. They're great. Here you can see a patient's angiograms with critical limb ischemia, the left panel before treatment, the right panel showing revascularization to the foot. But what the patient really cares about, this is the patient whose angiograms were just shown, the patient really cares about whether or not that foot heals, and if they have to have some tissue taken off, what's the minimal amount of tissue that can be taken off. And essentially that's a question of how do you get oxygenated blood delivered to the tissue, and how do you measure that? One of the things that is very obvious when you compare where we are in the peripheral arena in CLI compared to, say, the heart or the brain, we are just barely getting the beginning of understanding perfusion and how to assess it. In fact, in this article, which was just published this year, I think the statement sums it up very well. Currently, no reliable method for measuring the adequacy of lower limb perfusion exists. So what we are dealing with is multiple imperfect solutions. The first that we shouldn't ignore is the physical examination, looking at the foot, telling about the temperature, assessing for tissue loss. Next is the ankle brachial index. So this is helpful to a degree, but keep in mind that this is really a kind of a poor measure of whole limb perfusion, and it becomes completely unreliable with calcification. The PVR gets a little bit more regional, but it's still not specific to small areas, and it's only qualitative. It's not a quantitative study. One of the things that really is the mainstay right now is contrast angiography. The ideal is to establish inline flow to the affected angiosome. That's generally considered to be the kind of the gold standard of treatment. But those of you who treat CLI know very well that in reality, your patient's angiosomes may not quite match the multicolored pictures that you see in the textbook articles. Also, we know that very often inline flow to the affected angiosome is unattainable, so you now are looking at other things that become very important: the presence of collateral and its adequacy, the status of the plantar arch, and wound blush. So one of the things that helps us to understand the importance of the plantar arch comes from the Olive Registry. This is a Japanese registry. Aida and his colleagues have really studied CLI patients in this context. And if you look here, you can see that they started out with a total of 314 patients, and they assessed just the ones with one vessel runoff, breaking them down into those who had an intact pedal arch and those who did not have an intact pedal arch. So an example, on the left, this is a patient who has inline flow to the foot, but you really don't see any flow on the plantar surface. Another patient, one vessel runoff to the foot, but here you can see that there is a plantar arch. And so when they compared in this group of CLI patients how they did, you can see that group A, those who had an intact plantar arch, had a higher chance of limb salvage than those in group B where there was no intact plantar arch. So a simple angiographic assessment making a good prediction about wound healing. This is another study. This was presented by Dr. Tay, and this shows that if an arch is complete, it again very closely follows with limb salvage. So here in these patients in a 2-year follow-up period, if they had a complete plantar arch, the rate of healing was higher than those who had an absent plantar arch. And this clearly achieved statistical significance. And this was regardless of whether direct or indirect angiosomal revascularization had been achieved. Wound blush, as I mentioned, is also another important aspect from the angiogram of perfusion. Here you can see a patient who has a lesion between the 4th and the 5th toes with some degree of wound blush. After angioplasty to reestablish flow through the plantar arch, the wound blush improves. And so this is an angiographic finding. And is this valuable or not? Well, I think this study, published in the Journal of Vascular Surgery a few years back, really shows that this is valuable. If we look at patients who had Rutherford 5 or 6, treated with endovascular therapy, and then the angiograms were assessed to see whether or not there was discernible wound blush, what you can see is that In the y-axis, freedom from amputation over a long period of follow-up, much higher in those patients who had wound blush than in those patients who did not have wound blush. Simple angiographic finding, very predictive of outcome. If this was compared to inline flow according to an angiosome distribution, you can see that the predictive value of wound blush was better and in fact achieved statistical significance, whereas going in an angiosome distribution was helpful but did not achieve statistical significance. Now let's move on to some of the other measures of tissue perfusion. TCPO2 was first reported in 1982. Essentially, the patient has electrodes put on the chest as kind of a comparator and then placed on the feet. And in general, higher values correlate with healing, either of ulcers or after amputation. But there are some limitations. One is that the electrode measures only a small area and it's very superficial. So we don't really get a deep tissue evaluation using the TCPO2 approach. The measurements can be quite variable. In general, the norm is that normal patients will have about a 60 millimeter of mercury TCPO2. In patients with CLI, if there is a greater than 40 value, this predicts healing. Less than 20 generally predicts a failure of the intervention. And there are a number of things that can throw the TCPO2 off and cause it to be factitiously low. Things that are very common in CLI: edema, inflammation, cold, and vasoconstriction. Now I'd like to talk in the final minutes about a number of newer options that are available: perfusion angiography, methylene blue, and some of the other newer options. Perfusion angiography is essentially a modification of standard angiography. A catheter is placed in the popliteal artery and then an injection performed at 3 ml per second, typically for 3 seconds. And then there is lateral imaging of the foot and Phillips analysis of the outcome. So the study is hampered significantly by foot motion, so the foot is secured, as you can see here. This then will give information not about an angiosome, not about a specific vessel, but about a region of the foot. So here you can see the region of interest outlined in this patient. This is the curve of the density over time of contrast prior to intervention and after successful intervention, and you can see that there is a greater density after successful intervention. Another example of a successful intervention comparing the region of interest, you can see that the contrast hits earlier and goes to a higher level. And if patients had a failed intervention, then the curves were identical. So this does have some quantitative assessment of perfusion of the foot. These are some images that were shared with me by John Runback of the injection of methylene blue to assess a patient. This is a patient who had a lateral tarsal artery region wound. Here you can see the wound, and this is with an injection of methylene blue into the perineal artery. And what you can see is that the perfused region is more on the plantar surface of the foot and somewhat distant from this ulcerated region. Now, if we look at an anterior tibial injection in the same patient, you can see that the blush now is in the immediate proximity to the ulcerated region. And so what this can do is to give us a good indication that if the anterior tibial is treated, then there is perfusion of the ischemic region. There are a number of other techniques that can be used. Endocyanine green angiography. This is administered intravenously, activated by a laser, picked up by a special camera, and can also give us an idea about changes in perfusion pre and post intervention. CMR, or cardiovascular magnetic resonance, can also be used. However, this really only gives us information about the calf, so it's not really the detail that we need at this point. PET can also be used with 15 oxygen labeled water, showing the difference between a healthy volunteer's calf and a PAD subject. And we can also use contrast enhanced ultrasound with microspheres which have a gaseous core. So to summarize, for evaluating tissue perfusion, which really is crucially important for tissue healing, angiography is still the best thing that we have. TCPO2 is helpful, but with limitations, but there are certainly a lot of things in the pipeline that are exciting to assess for how well tissue is perfused. Thank you.